guys, welcome to BFR Tuesday. My name's Cara. I am your question guy here, so you can ask any questions you want of me from your either BFR experience or looking to get into BFR, but I answer all types of questions regarding rehab or programming, contraindications, whatever is kind of popping up and what you have questions about. So you can put any question you want into the chat section. So like I'll put in the chat section, it should be in your upper right corner. I'm saying hello from Dallas, Texas. Hey Chuck, good to have you on. All right, Lewis, a few weeks ago, I asked a question about studies referencing BFR programs such as high versus low pressures, rep schemes, etc. You mentioned your BFR programming course level 2, week 3 material when you posted a link to multiple studies. For whatever reason, I couldn't see that link posted in the chat. I messaged you via BFR University email, but I'm not sure if that was correct. Yeah, I just been overwhelmed. Let me see. I mean, there's so many studies, Lewis. I don't know how to really break it down. It's not like there's 1 or 2 studies. A lot of what you get from me is accumulation of 10, 15, 20, 30 studies, and then my interpretation on those. And, you know, a lot of it is, hey, they do this intervention and it's at this pressure and it's at this percentage of 1 rep max, and the person doesn't get a result. And then I have to say to myself, why didn't they get a result, but another group did get a result? And it's because this group was an elite athlete set and this was a sedentary set. So it's hard for me to pinpoint 1 or 2 studies and be like, hey, these are the studies. I mean, I'm happy to share. I mean, I've got over 1,000 studies on you know, some of the stuff that I'm teaching, but you know, to pinpoint it's just really difficult. I mean, it's impossible really, because there's no meta-analysis for me to point you to say like, hey, there's some best practices, and a lot of what I'm doing is based on what I'm seeing in the clinic and not necessarily all reference based. I'll send you some stuff that you can see, but you're gonna have to dig a little bit. I just don't have it, you know, fully all laid out. Any other, oh, by the way, video quality is so much better. Okay. Sure, Lewis, I'll send you that. I'll respond to your email and send you that link. All right, anybody else? Anybody else have any questions for me regarding BFR? All right, no other questions. If you could put in the chat your current experience with BFR, so I know who I'm kind of speaking with. So been using it for a while, been using it for rehab, using it on patients, using it on yourself, like just so I know who I'm speaking with today, and then I can think of some content or questions that I've gotten this week offline, and I can give a little information out. One year. Disorder smart cuts for 2 clinic outpatient patients have been training, but we're looking to incorporate more. Oh, great. Good to have you, Jason. Yeah, Jason, is there anything in particular that your staff is having questions about? I just did an in-service for a larger group PT clinic. I just did it as a Zoom, so also open to doing that as well for you and your staff if you ever need to, or they can jump on here and ask questions. Yeah, considerations for aerobic use. So there's really two different ways to think about aerobic with BFR. You can either do it like steady state, or you can do more sprint type work. And that sprint work can either be cycling, it can be running, it can be rowing. So kind of more interval type work, higher intensity. Most of our rehab patients are going to be in the steady state. Like, you're going to put them on the bike for 15, 20 minutes, and they're going to ride at 60% limb occlusion pressure in the lower extremity. And they're going to do that somewhere between 3 and 5 times per week. And they're going to get aerobic capacity adaptation. Our higher level people, which I go into a lot in depth with my level 2 course, is using more interval type training, either on the cycling, rowing, treadmill, outside sprinting, and then using BFR either during the activity or immediately after the activity to enhance their VO2 adaptation. So lots of considerations, but just as a general, like, hey, getting somebody started, steady state is really effective. 15, 20 minutes, 60% limb occlusion pressure in the lower extremity. Get them on a bike, get them walking, get them outside, and they'll have pretty quick adaptations between 3 and 4 weeks. And then the 30, 15, 15, 15 rep scheme is really good to kind of as a starting framework. And then as your clinicians get more comfortable, then you can start influencing what you're trying to get. Like with hypertrophy, I recommend using lighter loads but higher pressures. So like 20% 1 rep max, and using either 80 or 50% limb occlusion pressure, depending on upper or lower extremity. If you're looking for more strength, then using higher loads, so closer to 40% 1 rep max, and using lower pressures. So you can start manipulating those as people start to feel more comfortable. That's, again, a level 2 kind of course concept that I go into. 1 or 2 limbs on the bike. I always do 2 limbs whenever possible, unless there's a contraindication, like recent open wound, recent surgery. Otherwise, I'm always going bilateral. Yeah, Louis, yeah, you definitely get hypertrophy quick with BFR, which is cool. So that is funny. All right, any other questions today? All right, if not, I will be back next week to answer any questions. Today's the 14th, so tomorrow my BFR University newsletter will be going out. If you're not on the list, you can go to bfruniversity.com and sign up, and then you get it's every 2 weeks I put out a newsletter of, not my stuff mostly, it's mostly other people's stuff, things that have come up and research articles. And otherwise, I'm on here every Tuesday to answer questions. Jason asks, billing question, can you use vasopneumatic with therapeutic exercise? I guess if you document it, right, and you put the time involved. I don't know the exact definition of pneumatic. Like, does it need to be for lymphatic flow? Because if it does, then we're doing the opposite. So I'm not sure. You have to look at the AMA guidelines on vasopneumatic and what the definition is. And see if it fits. Primarily, I'm all cash, so I only just throw things underneath my office visit. I know most people use either therapeutic exercise, or they'll throw stim on with the cuffs, and they'll use Therex with e-stim. But if it falls within the guidelines of the definition of asymptomatic, then I don't see why not, because you are using an inflatable cuff. All right, thanks everybody so much for being here, and I will see you next week. If you have any other specific questions, you can reach out to me at I think I'm Dr. Cara at bfruniversity.com. Thanks so much.